Okay, we're going to continue with Chapter 42, Part 4, The Child with Cardiac Disorder. Let's talk about transposition of the great vessels. With the major arteries reserved, oxygen-poor blood returns to the right atrium from the body, passes into the right ventricle, then goes into the aorta and back to the body. And oxygen-rich blood returns to the left atrium from the lungs and passes into the left ventricle, which pumps it back to the lungs, the opposite of the way the blood normally circulates. The oxygen-poor blood cannot meet the body's demands, and this situation cannot support life. Transposition of the great vessels, also known as TGA, is almost always diagnosed in the first hours after birth. Most babies with TGA are born with a small hole between their atria, which allows just enough oxygenated blood to get to the body to maintain life for a few hours. TGA is life-threatening, and in order to survive, babies with TGA need special therapy urgently soon after birth. The most commonly used initial therapy is balloon atrial septostomy, where a balloon at the end of the catheter, like a small flexible tube, is used to enlarge the opening between the atria. Complete open heart repair generally takes place a few days later. If there are no unusual risk factors, more than 98% of surgically treated infants survive their infancy. Most children who have had transposition of the great vessel surgery actually recover and grow normally, although they can be at some risk in the future for arrhythmias, leaky valves, and other heart issues. Okay, now let's talk about total anomalous pulmonary venous connection. It's a rare defect characterized by failure of the pulmonary veins to join the left atrium. In this defect, the pulmonary veins join to the systemic venous circuit via the right atrium or various veins draining towards the right atrium, the SVC. You want to look at box 42-4 for additional classification of this disorder. Symptoms can include cyanosis developed early in life. Without intervention, cardiac failure occurs and will progress to death. For repair, it's performed early in infancy. Surgical approach varies with each anatomic defect. Prognosis for mortality is post-repair for all types is less than 10%. Morbidity increases with the presence of pulmonary vein obstruction. Now we'll talk about truncosardiosis, a defect that results in the development of a single vessel that overrides both ventricles. Blood from both ventricles mixes in the common great artery, leading to desaturation. There are three types. You want to be sure to look at box 42-4 of your textbook for more information. Symptoms: most infants have moderate to severe heart failure and variable cyanosis, poor growth, activity and feeding intolerance. There's a Holycystic murmur at the left sternal murmur with the diastolic murmur present if there is truncal regurgitation present. Early repair is performed in the first month of life. The VSD is closed during the repair. Prognosis: mortality is greater than 10%. Conduits placed during surgical repair will need to be replaced in future surgical procedures. Now let's talk about the hypoplastic left heart. There's an underdevelopment of the left side of the heart. It usually have an absent or non-functioning left ventricle and hypoplasia of the ascending aorta. Diagnosis can be made prenatally with an ultrasound. The infant may be placed on the transplant list soon after birth. Initial survival after birth depends on maintaining the patency of the ductus arteriosus and the foramen ovale, which allows the oxygenated blood to circulate throughout the body. Additional congenital anomalies may be present. Careful assessment of the infant at birth is very necessary. So let's talk about some clinical manifestations of signs and symptoms of heart failure. The symptoms could be mild cyanosis, and until the PDA closes, then progressive deterioration occurs. Treatment includes a multiple stage surgical approach. The first stage is the Norwood procedure with a modified Blaylock Taussig shunt and the creation of an ASD. The second stage is usually the Glenn shunt or a Hemi-Fontan operation. The final repair is modified Fontan procedure. You want to look at box 42-3, 42-4, and table 42-2. Transplant is a viable option for some infants. Look at pages 1351 and 1352. Prognosis: if it is left untreated, the condition will result in death in the first months of life. Prognosis depends on the stage of repair. 10 to 30% mortality after the first stage of surgery. There is a risk for death between each stage of surgery, and the mortality for the last two stages is less than 5%. So, heart failure. This is the inability of the heart to pump effectively. It may be right-sided, left-sided, or both. Each type of heart failure produces different manifestation, and it is unusual to observe just right or left-sided heart failure. Remember, if one chamber fails, the other chamber will attempt to pick up the slack, ultimately leading to failure of both chambers. Look at figure 42-6 on page 1331 for the pathophysiology of heart failure, and then look at box 42-5 on page 1332 for clinical manifestations of heart failure. Diagnosis of heart failure is made based on the clinical manifestations of tachycardia and tachypnea at rest, dyspnea during feeding, especially in infants, then weight gain caused by fluid retention, and hepatomegaly. Remember, when infants and children have feeding difficulties and fluid retention, think cardiac. Chest x-ray will show an enlarged cardiac silhouette, and echo is done to determine the potential causes. So think defect. So for treatment in nursing care, with the goal of improving cardiac function and cardiac output in mind, cardiac glycosides, ACE inhibitors, diuretics, beta blockers are likely to be used in the drug regimen of children with heart failure. Look at pages 1332 and 1333 for drug information. Table 42-1 on page 1233, look at diuretics that are used in heart failure. So what electrolyte levels should be monitored when using loop and thiazide diuretics? You're correct. Potassium. Potassium supplements may be prescribed. Remember to monitor digoxin levels in children taking digoxin or digitalis and monitor for signs of dig toxicity. See box 42-6 on page 1335. Make sure you count the apical pulse for 1 full minute prior to administering the dig, and then hold if the pulse is less than 90 to 110 in infants and young children if it is below 70 in older children. Hold if it's less than 60 in adults, of course. Typically, digoxin orders will be written to include the heart rate parameters for holding the drug. For children receiving ACE inhibitors, be sure to monitor the child's blood pressure and renal function. Decrease the workload of the heart by providing a neutral thermal environment to prevent cold stress in infants. It's also important that infections are treated appropriately. Place children in the semi-Fowler or high Fowler position to decrease respiratory effort. Decrease environmental stimuli and encourage rest. Combine care to avoid unnecessary interruption in the child's rest. Plan fluid restrictions by using a 24-hour fluid intake schedule, and you want to teach the family about the medications and treatment plan. See your nursing care plan for the child with heart failure on pages 1334 and 1335. I want to talk about hypoxemia. This is a condition in which arterial oxygen tension is less than normal. It's identified by a decreased arterial oxygen saturation, also known as hypoxia. Results in cyanosis, polycythemia, and clubbing of fingers. So, for nursing care and care of the family and the child with congenital heart disease, you want to help the family adjust to the disorder, educate the family about the disease, help families manage the illness at home, prepare the child and family for invasive procedures, provide post-operative care such as frequent vital signs, neural checks post-op, watch for symptoms of thrombus formation, look at box 42-7 for selected complications after cardiac surgery and treatment approaches. Plan for discharge and home care. Educate parents to not overprotect and restrict children from normal activities related to growth and development. Competitive sports are avoided for children with CHD because the pressure to win may keep the child from stopping play if symptoms arise, which can cause bad news. Taking them to school versus making them walk may save energy for school and activities and prevent overtiring. So some of the parents' fears, you want to make sure to teach parents that their fear and anxiety may be transferred to their child. For health maintenance, emphasize education regarding the importance of maintenance of general health. Dental hygiene, maintaining dental health is important to prevent bacteremia, which can cause bacterial endocarditis. They will need prophylactic antibiotics prior to any dental procedure. You want to educate parents on providing children with proper nutrition. The goal is to prevent anemia and promote optimal growth and development, and instruct parents on the importance of keeping immunizations up to date. Look at pages 1339 to 1344. This concludes part 4 of congenital heart defects.